Last week, we heard from Mitchell around the barriers that sex workers face when trying to access public healthcare facilities, criminalization, and the stigma that often follows them through the door. And that's not really going to change with lenacapavir. Previously, community-led drop-in centers were a lifeline for a lot of members of key population communities to actually safely access sexual and reproductive health services. But last year's funding cuts have stripped many of those spaces away. And now we exist in this paradox where there's significant investment going into LEN, which makes sense, but the very programs that would have made LEN reachable for key population communities are no longer being funded. So what do we do about that? Remember Mitchell from our last video? Well, she's back to unpack this very paradox with us. So over to her.
The people who are supposed to educate the community, we are supposed to do the referrals, the peer educators are not even there to build a trust on the ground to administer, because of course there is the information, but you refer someone to the clinic and they're not able to access it, means that there is a gap there. The rollout that works for Zimbabwe must be decentralization, because when we say what do we say on decentralization? It basically means that this looks like the mobile clinics, the outreach that we conduct, the community-led distribution, where sex workers are also trained, are also in charge of being the ones at the forefront of disseminating the service to others, because nothing for us without us. And who needs to be at the table where these talks are going to be done? It basically means us, the community, we have to lead the groups, the technical leads. We also need the law enforcement sensitized that they don't see a woman carrying prevention kit as evidence of crime. They don't see a person going to the clinic as an evidence of crime. We need to be at the table to ensure that rollout is by us for us, nothing for us without us.